Okay, thank you so much, Dr. Koshik, and thank you for all the faculty for giving me this opportunity to participate and help. Am I audible?
Yes, yes, perfect.
Okay, great. So this presentation, basically, all the questions are from past candidate experiences. So it's all real questions from FRCS Glasgow Viva exams. And all the answers I got from Kansky as the main source for all answers. Only few additions in few topics. And actually, I quoted from Kansky for two reasons. Firstly, to be easily absorbed and retained, because I know that most of the candidates already read Kansky before, and many of them are using Kansky as the main source for revising the information. And secondly, because it's one of the most comprehensive and sufficient resources for FRCS exam. Actually, before giving the exam, one of my colleagues who gave the exam before me told me that examiners usually stick to Kansky, and that was really true. They usually do not go any further or beyond Kansky informations or the informations that are given in Kansky. So if you stick to Kansky and if you know it by heart, you will pass. Okay, so firstly, I will start with one of the most common cases. And I had that case actually in my exam, a case of 8-year-old boy with eye pain and lid swelling since 2 days. So we have a very large differential diagnosis, and I got that table from Kansky for all the acutely inflamed orbital swellings. But those are the most common three and the most important three infectious causes for the lid swelling and eye pain. So firstly, the orbital cellulitis, secondly, preseptal cellulitis, and thirdly, conjunctivitis. And usually when you get such a scenario and the examiner wants you to discuss the infectious causes, he will ask you how to differentiate between orbital cellulitis and preseptal cellulitis. And that is one of the most important questions. So how to differentiate? I don't know, would you prefer to make it interactive so we can take answers from the audience, from the
Yes,
candidates?
yes, Dr. Amar. You can please ask any candidate or any candidates can please volunteer.
Okay, so anyone would volunteer to answer how to differentiate between orbital and preseptal cellulitis?
In orbital, there'll be restriction of extraocular movements and proptosis will be elicited in orbital. In preseptal, it will involve the tissue only before, after the septa. So that's how we differentiate orbital from preseptal.
There will
Okay.
be changes in the optic nerve functions and there will be limitation of extraocular movements as well.
Pupillary
Yes.
reaction we need to check.
Yes, definitely. So as you mentioned, preseptal cellulitis in the imaging, firstly, preseptal cellulitis, usually the inflammation and the infection will not cross the orbital, the septum. But in orbital cellulitis, you will have the inflammation and the infection involving the orbital contents and the orbit. That's first thing regarding the imaging. Usually, orbital cellulitis patients will have more toxic presentation with high fever, lethargy, and definitely proptosis, limitation of extraocular motility, as you mentioned, affection of the optic nerve because of compressive optic neuropathy, decreased vision. So here, these are two examples. That one, orbital cellulitis with proptosis, conjunctival chemosis, severe lid erythema, and here the CT showing the infection involving the orbital contents. But here, Preseptal cellulitis, severe lid swelling, but the inflammation does not involve the orbit. It's only before the orbital septum. One important note is in very small children, especially children who are less than 5-year-old, you need to treat them aggressively. Many of them would need admission and IV antibiotics because they have a very thin septum, and preseptal cellulitis can be orbital cellulitis, can progress to orbital cellulitis within few hours or within 1 or 2 days. So in small children, usually we should treat them aggressively and monitor them more closely. So what are the investigations that we usually need to do for such patient?
For orbital cellulitis, we need to go for first this hematological evaluation,
Okay.
complete blood pictures, and we have to need to go for this CT scan as we showed.
Okay.
And blood cultures also we have to
Blood
send.
cultures.
Okay.
Color vision,
Yes.
Optic nerve functions all.
no functions should be checked, and they should be serially checked to make sure that it is showing improvement.
Every 4 hourly we can check to serially.
Optic nerve functions. Yes,
Yes,
definitely.
sir.
You said
Extraocular
everything.
movement.
I would just make it more organized. So regarding ophthalmological evaluation, you need to check the visual acuity, color vision, fundus examination, extraocular motility, then lab, CBC, and other blood cultures, culture of nasal discharge if you are suspecting orbital cellulitis due to sinusitis, which is one of the most common causes. And then we move to the high resolution CT of the orbit, sinuses, brain. And it's really important to do the CT for all these structures to know exactly what is the pathology and to know the extent of the infection, because sometimes orbital cellulitis might involve the brain and it can cause brain abscess. And also it's very important to do CT to exclude subperiosteal abscess as well, because in such cases, usually patient will not improve with antibiotics and they might need drainage to improve. Okay, regarding the treatment,
We will
any
start the patient on IV antibiotics. Mostly the infection is due to a gram-positive bacterium.
Okay.
So,
Can you
presumably,
give me
any
some
penicillin
examples?
derivative like
Yeah.
Third generation cephalosporins and metronidazole. We'll start the patient IV.
Okay. So yeah.
metronidazole for gram-negative and anaerobic, possibly ceftriaxone, or I'm not too sure.
So ceftazidime can be used. Cephalosporins like ceftriaxone also can be used with the addition of oral metronidazole to cover anaerobes. And usually we give the intravenous antibiotics for 4 days. Then we can continue on oral antibiotics after the patient become afebrile and the patient shows improvement. As you mentioned, also, we need to do monitoring for the optic nerve function every 4 hours initially. Visual acuity, color vision, pupillary reaction, and delineation of the extent of erythema. I think many of us would forget this. This is important to judge the progress, to see whether the patient is improving or not objectively. And definitely hospital admission, and always do not forget to ask for ENT consultation and to ask for infectious disease specialist consultation in some cases. Finally, in those patients with orbital abscess or subperiosteal abscess, those patients might need drainage for the abscess or the drainage of the infected sinuses if there is no response to antibiotics. And if the patient is having severe optic nerve compression, patient might need emergency canthotomy or canthalysis. Okay, that is one of the most important and most and very common question in the Viva. And you need to know it by heart because such cases, emergency cases, you need to know all the details about it. I will move to the next case. So a 4-year-old child present with ptosis, and that ptosis corrected by jaw movement. And you will see that almost all the pictures I have in that presentation also from Kansky to make it more familiar. So any ideas?
So in the first picture, it's showing there is a ptosis of the left eye. And in the
Okay.
second picture, when there's the child is opening his mouth, ptosis is resolving. So this could be a Marker-Gunn jaw winking syndrome.
Exactly. So what about the postulated pathology for this disease or this problem?
There is a synkinetic innervation with the internal pterygoid muscle.
Okay,
Yes.
great. So that is Marcus-Gunn jaw winking syndrome. And etiology is unclear, but one of the postulation that there is the branch of mandibular division of the fifth cranial nerve misdirected to the levator muscle. So the signs, retraction of the ptotic lid in conjunction with the stimulation of the ipsilateral pterygoid muscle by chewing, sucking, opening the mouth, or contralateral jaw movement. And there are also less common stimuli like jaw protrusion, smiling, swallowing. And jaw winking usually does not improve with age, but patient learn how to mask it. But usually it persists. So how to treat? Any volunteer?
So, sir, if there is a significant jaw winking, we have to do levator deinsertion along with the frontalis sling. But if it is a mild case, in case of mild case, we can do only levator advancement like levator resection.
Great. And if it is unilateral, as most of the cases, how would you approach? Would you do unilateral or bilateral surgery?
Bilateral.
Bilateral. We have to do the bilateral.
Okay, great. I would like to say something about almost all pediatric cases. Always remember two things. Firstly, to correct the refractive errors. Secondly, to treat my amblyopia. So always remember these 2 points in each pediatric case. Firstly, correct the refractive error. Secondly, treat amblyopia. Thirdly, treat the pathology, whether it is ptosis, whether it is strabismus, or any other pathology. Always remember refractive errors. Always remember amblyopia. And usually we treat congenital ptosis, whether it is Marcus-Gunn jaw winking or any other type of congenital ptosis, whenever it is significant. Whenever it is significant, whether the patient is having AHP, anomalous head position, or it is closing the visual axis, it is covering the pupil. And sometimes if it is causing significant meridional amblyopia also. So surgery should be considered if jaw winking or ptosis is represent a significant functional or cosmetic problem. Amblyopia, cosmetic, or AHP. In mild cases, with reasonable levator function. Mild cases of jaw winking with reasonable levator function of 5 mm or better, little synkinetic movement may be treated with unilateral levator advancement or resection. In moderate cases, unilateral levator disinsertion can be performed to address the synkinetic winking component with ipsilateral frontalis suspension or the sling, and bilateral levator disinsertion with bilateral brow suspension may be carried out to produce symmetrical results.
Dr. Amar, I have a question here, sorry.
Yes.
Is levator advancement different from levator resection?
Yes, and in levator advancement, you know, I will give you an example in the strabismus cases. So, for example, you have medial rectus resection and
Right.
medial rectus advancement. So advancement is one of the tightening procedures that can be
Okay.
used if you have levator
Okay.
disinsertion. So you can use only advancement, and you can use advancement plus resection. So you can use them both together, or you can do advancement only or resection only, depending on the case.
Okay. Okay.
Okay.
Thank you.
Sir, you will answer it is bilateral. You have to do bilateral or unilateral.
So I think in cases of bilateral ptosis with jaw winking, you need to do bilateral surgery to have symmetrical results. And even if the patient is having unilateral Marcus gun, and I think bilateral usually is the rule in Marcus gun, but I would like also to listen from other members if they have more experience in this. But as I know, usually bilateral is needed in severe cases to produce symmetrical results.
Okay, sir.
Any inputs from the respected members? Anyone can add on this point?
Dr. Demia?
Sir, I'm not very sure what I heard. Is if a Marcus gun with a ptosis, if the ptosis is severe, we have to correct the ptosis first. Ptosis. If the Marcus gun is more, then we have to correct the Marcus gun component first. Means if the cosmetic appearance is very severe and ptosis is not that much, then you have to go for the levator disinsertion, means whatever sir told. But if the ptosis is more, then you have to do the levator section. This is I have heard from the Santosh Hanava's class. But as per Kansky, whatever sir told is okay. But this is what I heard from Santosh Hanava's class.
So it is better to go with the book. Whenever there is a controversy, it is always better to speak to Kansky because nobody will be questioning on that.
Yeah, I think also I will search for this and I will give answer on the group.
Yes.
So I can I just from actually I'm a ophthalmology fellow. Sir, in practice we usually do for like as sir told, for mild cases we can just like if it is a mild ptosis and that patient is able to like that harsh work, if we do an MRD1, if it is clear, then we need not to touch it. Because for
Yes.
small errors, if we correct, then it will be like problematic for the patient also. So for like mild Marcus gun with mild ptosis, we can leave for the patient whether he want or not. That is for just a cosmetic reason. But for moderate cases, the like MRD1 is also very like we usually actually see how much with jaw movement, how much patient has corrected ptosis. Like if it is more than 2 mm, like if it is like elevation is too much, then we should do the LPS disinsertion with frontalis sling. Even in like if it is unilateral, then we usually do unilateral also. We do not do like we do not go for the both the eyes ptosis correction. So, like for moderate cases, it just we just usually see how much correction with jaw winking, we have.
Mhm.
If it is more than 2 mm, then we should do. Otherwise, we can just leave. Then, if it is very severe ptosis, then we should correct. And in that cases, we can go for both the eyes, ptosis correction.
Okay. Thank you so much. Thank you so much for your input.
Thank you.
Okay. So, moving to the third case, infant is diagnosed with ROP, retinopathy of prematurity. That's also one of the questions that is recurrent in many exams, and you really need to know it by heart. In one of the exam experiences, they asked the candidate to draw the zones. So you should understand and you should really absorb the topic. Do not just memorize it. So I will try in the next few slides to simplify ROP as much as possible. So firstly, the screening, and I think it was discussed in the group whether to use the UK screening protocols or the local screening protocols in your country, whether India, Pakistan, or Yemen, or any other country. Actually, I don't have a clear answer for this question, but I think we should, or we may use the UK screen protocol as it is UK based exam. Or if the examiner asked you, what are you doing in your country, or what are you doing in your practice, then you can use the local protocols. But the differences are not that much. So usually the screening, anyone would like to volunteer when to screen the premature infants?
Sir, we have to screen the patient, the premature baby, the one who born before 30 weeks,
Okay.
or the weight is of the baby is the less than 1.5 gram kg,
Yes.
so 1500 gram, less than 1500 gram, or the patient have his oxygen supply, or he is in an incubator period more than week, then we have to screen that patient. And if the patient have any transfusions or unusual course during delivery or during pregnancy, then we have to for this ROP, screen the patient for ROP.
Exactly. Any other things that we might consider to screen babies for ROP?
Septicemia, sepsis, and jaundice. Sick baby.
Sepsis,
Any sick
enterocolitis.
baby. Any sick
Oxygen
baby.
exposure.
Yes, definitely. So the criteria for the healthy premature infants, if the infant was born 30 weeks gestational age or younger, or the weight 1500 grams or less. Also, if the child was born after 30 weeks or weight is above 1500 grams, but he has other comorbidities, severe illness, sepsis, other problems, also those infants or premature babies need screening as well. Okay, so when usually we do the screening? As soon as the baby born, or there is a specific
4 to
criteria?
6 weeks after birth.
Sir, actually,
31 weeks or 4 weeks later, which one is later?
Later.
Exactly. So whether 4 weeks after birth or 31 weeks gestational age, whichever is later. So what does that mean? For example, if the child was born at 23 weeks or 24 weeks gestational age, so we will wait till 30 or 31 weeks gestational age. That is 7 to 8 weeks actually. If the child, for example, was born at 26 or 27 weeks gestational age, then we will wait for 4 weeks and then we will do the screening. So begin 4 weeks postnatally or 30 or 31 weeks gestational age, whichever is later. And the subsequent review, usually 1 to 3 weeks intervals, depending on the severity of the disease. And usually we continue till full retinal vascularization of the zone 3. So that is the endpoint of the screening for those babies, whenever the retinal vascularization is complete. About 10% of the babies screened require treatment, and always remember the complications of ROP. What are the complications that can happen to those babies, even if they passed that dangerous phase and they were treated whether with laser injections or anything else? What are the complications that can happen on the long term?
They can have a myopia, high myopia.
Yes.
Strabismus, amblyopia.
Yes, exactly. So those children will need more frequent follow-ups than normal children because they have a higher risk of refractive errors, especially myopia, strabismus, and amblyopia. Okay, so here we will talk about zones. So we have zone 1 and zone 2 and zone 3. Zone 3 is the easiest. It is the temporal crescent. And we have zone 1. The center of the zone 1 is the optic disc. And the distance between the optic disc and the fovea, 2 times temporal to the disc and 2 times nasal to the disc. That is zone 1. So from the disc to fovea, that is half the distance. Then from fovea to the border of the zone 1, that is the other half. And same thing on the nasal side. So that is zone 1. Circle centered on optic disc, optic nerve, radius equal to by distance from nerve to fovea. Then we have zone 2. Zone 2, it is concentric annular area from the outer border of the zone 1. It reached the nasal ora serrata and just beyond the equator temporally. And we have zone 3, as I mentioned, it is only the temporal crescent from outer border of zone 2 to temporal ora serrata, So in ROP, you need to be familiar with zones and you need to be familiar with clock hours because usually we describe the stages and we should also mention how many clock hours the patient is having. For example, patient is having stage 3 in zone 2, 5 clock hours, 4 clock hours, like that. So coming to ROP stages, anyone can volunteer?
Stage.
First
Yes.
line of demarcation, then there is ridge formation,
Yes.
then extravascular proliferation,
Yes.
then retinal detachment, first subtotal, then going to total RD.
Exactly. Only in the subtotal we have two subclasses.
4A.
4A and 4B.
Yes.
Foveal and
4A.
extrafoveal.
Yeah, 4A.
Yes, 4A
Extrafoveal.
if it is extra, 4B if it is involving the fovea. And stage 5 total retinal detachment. Again, in stage 5 we have two morphologies. We have whether closed funnel or open funnel retinal detachment. So we have also stage 0 actually, which is not mentioned here, which is the immature retina. So whenever you are screening a baby and he has a part which is immature, but there is no line of demarcation or no ridge or anything else, so we call it stage 0. For example, in this child, you have stage 0 in zone 3. Okay, so stage 1, simply it is a demarcation line, which is flat line, only a line between the vascular area and the avascular area, only line demarcating or separating the vascularized from the avascularized area. Stage 2, that flat line now has a height and it's forming a ridge. Okay, that is stage 2. Again, that ridge usually will be between the vascularized and avascularized areas. Stage 3, that ridge now is having new vascularizations. So whenever there is new vascularizations, now you are in stage 3. And because of new vascularization, you will start having traction, and traction will lead you to stage 4. And that traction, if it is involving, if it is not involving the fovea, extrafoveal, that is 4A. If it is involving the fovea, then that is 4B. And if it is, that is 4B involving, we have here, that was stage 3 before. It was neovascularization, and then traction happened, and that traction involving the foveal area. So that is stage 4B. And we have then stage 5, which is total retinal detachment. We have closed funnel and open funnel. Usually open funnel firstly, then closed funnel is the late stage, and we will have that very sad appearance of detached retina behind the lens, which is one of the earliest names for the ROP. Anyone knows the name?
Retrolental fibroplasia.
Yes, yes, because in that time, they have all the patients in that stage, unfortunately, or many of the patients in that stage. So in addition to the stages, we have other things that is important in classifying and categorizing the patients. We have something called plus disease. So in plus disease, we have dilation of the posterior retinal vessels and tortuosity of the posterior retinal arteries. Okay. So usually, if the patient is having that vascular abnormality, that tortuosity in 2 or more quadrants, that is plus disease. If the patient is having that vascular abnormality in only 1 quadrant, that we call pre-plus disease. So we have pre-plus and plus disease. Plus if it is 2 quadrants or more, and pre-plus if it is only in 1 quadrant. So here we have 2 important features in plus disease: venular dilatation and arteriolar tortuosity. Pre-plus, as I mentioned, if we have arterial tortuosity and venous dilatation, more than normal, but less than sufficient for the diagnosis of plus disease and involving only 1 quadrant. We have also something called APROP, the aggressive form of ROP, aggressive ROP. The problem of aggressive ROP that it is progressing very fast. And usually it involves the zone 1 or posterior zone 2. So it is posterior ROP involving the posterior pole. So patient will have usually prominent plus disease and ill-defined nature of retinopathy. It's not sticking to the classical stages. You will find hemorrhages, you will find new vascularizations, and you will find definitely plus disease, and usually it needs immediate treatment. So here we have posterior disease and prominence of plus disease and stage 3 in zone 1. Okay, coming to ROP types. Anyone has any questions so far?
What are the cicatricial types about it?
Yes, cicatricial part of ROP usually in the end stages, in the stage ROP, like stage 5. I didn't prepare many slides about cicatricial ROP, but we can go and discuss it after finishing 2 or 3 slides. So regarding ROP types, we have old classification, and that involves threshold disease. And we have new classification that involved something called type 1 and type 2 ROP. Anyone can tell us what is type 1 ROP?
Type 1 ROP, which requires the urgent treatment within the 24 to 48 hours. And the type 2 ROP, which we can even observation plus treatment up to 1 week.
Exactly. Can you tell me the criteria for type 1?
Right.
And
Yeah.
Yes, go ahead, please.
okay, any disease, any stage in zone 1 or a stage 2 or is 3 in a zone 2 with or without plus disease.
I will add.
And stage 3 within zone 1 also.
See, stage 3 without plus in zone 1, stage 2 or 3. I have it here. I will also
Stage
show it.
3
In
without
zone
plus.
1.
So any ROP stage in zone 1 with plus, any stage in zone 1 with plus, stage 3 without plus in zone 1, stage 2 or 3 in zone 2 with plus.
Plus.
So you have 2 with plus, 1 without plus. So if it is in zone 1, any ROP stage in zone 1 with plus, that is type 1. It require urgent treatment. Stage 3 in zone 1, even without plus, that is also require urgent treatment. And if you have a stage 2 or 3 in zone 2 with plus. Okay. Can you please mute? Hello? Can you hear me?
Yes.
Okay. So type 1, as I mentioned, any ROP stage in zone 1 with plus, or stage 3 without plus in zone 1, or stage 2 or 3 in zone 2 with plus. Type 2 ROP, that is usually requires observation, and that is a stage 1 or 2 in zone 1 without plus, or stage 3 in zone 2 without plus. Okay, so regarding the treatment for ROP, what are the treatment modalities that we can use? Any
laser photocoagulation of the avascular retina.
Yes.
If laser is not available, cryo can be done to the avascular retina, and now bevacizumab, ranibizumab, and aflibercept are also being used with
Great.
good results.
So what is the difference between cryo and laser, and which one is better?
Sir, laser is better than cryo.
Okay.
Because cryo
Why?
causes a lot of inflammation and can cause
Okay.
tractional RD by itself.
Okay. And it causes more anatomical changes
Distortion.
than laser. Laser usually preserve the anatomy, and it is less inflammatory, as you mentioned. Okay. What other types of treatment other than laser?
Anti-VEGF.
Anti-VEGF. What are the anti-VEGFs that can be used?
The most we use this ranibizumab can be used, or acid.
Okay.
Yes, mostly we use ranibizumab.
Why? Why ranibizumab, not bevacizumab?
Actually, ranibizumab only works on the eye, and bevacizumab can act on other parts of the body.
Exactly. So ranibizumab, theoretically at least, it's more safe. And actually, till now, we don't know exactly what are the long-term outcomes of anti-VEGF on those babies. So it is given in many parts of the world, but till now, still we don't know the systemic complications and the long-term effects in that age group, the premature infants. One more disadvantage of intravitreal anti-VEGF. Who can say it?
Yeah, in anti-VEGF, it can cause the disease can come back. So we have to keep a good follow-up for like 70 or 80 weeks.
Exactly. So whenever you are doing laser for the patient and you are lasering the avascular area, then you can follow up the patient maybe 2 weeks after the laser, and then you see if the patient needs more laser or not. If the patient does not need laser, then usually you can stop following the patient for any active ROP after maybe 1 month after the laser, if everything is okay and the new vascularization regresses. But the problem with anti-VEGF that anti-VEGF action will be for how long? The action of
4 to 8,
anti-VEGF?
4 to 8 weeks, depending on which
Yes,
agent we are using.
exactly. So after 4 weeks, what will happen? Patient might have again relapse, and the new vascularization might appear again and again and again. So those child might need injections, more than one injection. That is one thing. Second thing, that you need to follow those patients maybe till 70 weeks of gestation or 80 weeks of gestation till you make sure that there is no risk of relapse or there is no risk of new vascularization anymore. Okay, then we have the third modality of treatment, that is pars plana vitrectomy. Usually we do that for whom?
Stage 4. Stage 4.
Best results are with stage 4A.
Yes, exactly. So usually PPV for patient with stage 4 or stage 5, and the best results for stage 4A with 90% success, anatomical success. Then we have 4B with 60% success, and unfortunately stage 5 with only 20% success rate. Okay. I will move to the second question, a case scenario of a child with nasal, with discharge and lacrimation. That question came in 2022. Another scenario, 1-year-old boy, mother complaining of watery eyes. So who can tell me the differential diagnosis of such case?
So for this, the differential diagnosis could be a conjunctivitis or nasolacrimal duct obstruction.
Okay.
Or any or viral infection or any.
Okay, so conjunctivitis, nasolacrimal duct obstruction. What else? Glaucoma. Yes. What
Yes.
else?
Yes.
Foreign body epithelial defect. What else? Uveitis also.
Allergic conjunctivitis, allergic
Yes, allergy also is one of the differential, but usually in such age, it's not very common. But yes, again, it's one of the causes. So when we are dealing with watering eye, like patient with watery eye, we have two causes, whether hypersecretion or defective drainage. Hypersecretion, usually it will be due to any ocular surface disease, inflammation, dry eye in adult patient, not in children usually. And the other cause, defective drainage, due to compromised lacrimal drainage system. This might cause be malposition and obstruction in such age, obstruction at any point along the drainage system. Lacrimal pump failure, that is also in elderly patient with facial nerve palsy. So usually the obstruction in infants will be at which point of the lacrimal system?
nasolacrimal duct.
At the valve of Fashner.
Yes, at the end of the nasolacrimal duct, at the valve of Hasner, usually the obstruction will be at this point. Signs, epiphora, matting of eyelashes, Rho plus positive. When you gentle pressure over the lacrimal sac, you may have mucopurulent reflux, and normal visual function should be confirmed as far as possible, and the anterior segment examination with assessment of red reflex. One of the most important tests is the fluorescein disappearance test. Very easy, very simple, and highly specific. So you put you install the fluorescein in the eye, and you wait 5 to 10 minutes. And then if you find after 10 minutes that still patient is having dye retained in the conjunctival sac, that means the patient is having a problem in the drainage, defective drainage.
So how often in real world scenario is it done before it's That is
Dye disappearance, yeah, I usually do it.
okay.
And it's very simple, and you can do it easily. And even after putting the fluorescein and after making the patient wait for 10 minutes and then call the patient back, you can easily use only the indirect ophthalmoscope with the blue filter. And
Okay.
you can see if there is still fluorescence or not. Very easy, very simple, and highly specific.
How much of fluorescent? One drop of fluorescent.
One drop is enough.
Okay.
And if you have fluorescent strips, you can put one anesthetic eye drops or normal saline or distilled water, and then also put it inside the eye of the infant, and then wait.
Okay.
Okay. So regarding the cases of nasolacrimal duct obstruction, what is the management? How would you approach those patients? So, for example, the same scenario. You have 1 month, 4-month old baby with lacrimation, and you did everything. All the examination is normal. Only the patient is having congenital nasolacrimal duct obstruction. What will you do?
We'll advise the parents to do Krigler's massage about
Exactly.
10 strokes 4 times daily.
Okay.
And we'll wait for about 1 to 1.5 years. If the means usually resolves spontaneously with the lacrimal massage, and if it is not resolving, then you have to go for probing of the nasolacrimal duct.
Exactly. So usually those patients, 90 to 95% of patients will have a spontaneous resolution with only the massage. You can also instruct the parents if the child is having any swelling in the medial canthal area or redness in the eye, any signs of infection, he should come back and so you can treat the child. If he is having only conjunctivitis, you can give topical antibiotics like erythromycin or topramycin. If the child is having more severe infection like dacryocystitis, then the child might need systemic antibiotics. And then usually we wait till the age of 1 year or 1.5 years, then we will see. If still patient is having persistent lacrimation and nasolacrimal duct obstruction is still there, then we will proceed for probing. Probing and
so even after an episode of dacryocystitis, we will wait for 1.5 years.
no, if the patient is developed dacryocystitis, usually you will do probing earlier, definitely. Definitely. But if the child is having only epiphora, eyelash matting, then you can wait till the age of 1 year. Okay. So usually we do probing and
irrigation.
Yes, probing and syringing or probing and irrigation. Actually, that was one of the questions for one of the past candidates. Because of that, I thought I will say it. So they were waiting the candidate to say syringing. So usually we do the probing, then we do syringing, use the fluorescein and inject and use nasal cannula to see if the fluorescein is retained through the nasal cavity. So that will confirm that you have a patent nasolacrimal duct. Okay. If the child had a failed probing, what would you do?
We can repeat the probing after 6 months.
Okay. That is one option. You can repeat probing only. What other options we have?
Stent. Nasolacrimal stent.
Balloon dacryocytoplasty with endoscopic visualization with stenting.
Definitely. So usually if the patient is having failed probing, so for the next one, it is always preferable to do the second probing with under direct visualization of the nasal cavity to see if there is any other abnormalities because of that the first probing failed. And you can use whether monocanalular or bicanalular stenting, or you can use also ballooning for such patients. Okay, and when usually we go for DCR for those children?
After 5 years, 5 to 7 years.
Yes, exactly. So usually after 5 years, actually, that is not my subspecialty, but I asked one of my oculoplasty colleagues. So he said usually after 5 years, if the patient had failed probing, then we can go for DCR. Because of the bone maturation and many anatomical changes, usually probing after the age of 5 years will not be successful. Okay, so we will come to the second most important differential diagnosis. Before going to that, I would like to just highlight one important point, that usually in such patient, when the patient come to you, do not forget to do a full examination of the eye. Do not forget to do cycloplegic refraction and fundus examination, because the patient might have significant refractive error or any other abnormality that's not related to nasolacrimal duct obstruction. So it's always better to do full examination for the child at least once. Okay. So coming to the second most important differential diagnosis, the congenital glaucoma. And you usually, you should always exclude congenital glaucoma in any patient with epiphora. So the classification of pediatric glaucoma, we have 3 categories according to the age. Anyone can help in that?
One is neonatal, infantile, and juvenile.
Okay, so we have congenital, infantile, juvenile.
Juvenile.
So congenital usually,
During intrauterine life.
yes, patient will have elevated IUP in intrauterine life. Infantile till the age of 3 years. And juvenile from 3 to 16 years, which is the least common. Okay, so diagnosis of congenital glaucoma, we have triad. Who can say that?
Blepharospasm, epiphora, and photophobia.
Exactly. And other signs that we can find in patient with congenital glaucoma? Signs?
Ophthalmos. Enlarged corneal diameter.
Okay, so ophthalmos, corneal haze, abstria.
Stria.
Yes. Optic disc cupping, of course. But one good thing about congenital glaucoma, if they treated early, that optic disc cupping can have a reversal. Reversal of cupping can happen in small children. And that is a very good advantage for such children. Okay, so if we usually we will do examination under anesthesia to those patients. Am I right? So what are the things that we will look for in examination under anesthesia? Anyone can enumerate them? That's very important for the exam. You need to know them by heart.
We check the corneal diameters.
Okay,
We check
corneal diameter.
intraocular pressure by Shorts or Perkins that we have, and we check the anterior chamber depth. We check for any lens, whether there's any ectopia lentis, and then we check the disc for any glaucomatous optic neuropathy.
Great. What else?
And retinoscopy will be done.
Yes.
Great. Yes. What else? One more thing.
Gonioscopy.
Gonioscopy.
Direct gonioscopy.
Exactly. Thank you so much. Yes. So IUP measurement, and usually you should do the IUP measurement in the beginning, whenever they are still doing the, the induction for the anesthesia. So anesthesia will not affect the measurement so much. Then you will proceed with other things: anterior chamber examination, optic disc examination, corneal diameters, gonioscopy, refraction, as you mentioned. Okay, so these are some pictures here: the blepharospasm, habs striae, both ophthalmos with corneal haze. Even here also patient is having ophthalmos, but it is asymmetrical, more in the right eye. Okay, so management of congenital glaucoma, who can help?
Maybe surgical. Initially,
Yes.
anti-glaucoma drops might be given, but the main target should be surgical. Like,
Why?
Why?
Because there is a problem of ankle dysgenesis in the congenital
Dysgenesis.
glaucoma.
Exactly.
So
the
it's depend
problem
upon.
is anatomy of the angle is abnormal.
Yes.
So usually eye drops will not help much as a permanent measure. You can use it as a temporary measure till you will do the definitive surgical management for such children. So what are the surgical modalities that can we use?
It's depend upon the status of a cornea. If a cornea is clear,
Exactly.
then we can go for goniotomy.
Okay.
If the cornea is a haze, yes.
Yes, if it is not clear, what will you do?
Then we can go for the trabeculectomy or trabeculectomy.
Okay, so you have
trabeculotomy
trabeculotomy and trabeculectomy.
Trabeculectomy.
And usually glaucoma consultants will do trap plus trap. They sometimes they do both procedures together. They do trabeculotomy plus trabeculectomy, or they can do staged procedures in some cases where they will do firstly trabeculotomy, for example, then second procedure, if it failed, they will go for trabeculectomy or goniotomy, then trabeculectomy. Then finally, if all these failed, what they will do?
We can go for the implants. There's many implants.
Drainage devices.
Yeah, glaucoma
And
drainage devices.
Glaucoma drainage device.
And the last measure, what can we do?
Cyclodestructive procedures.
Yes, cyclodestructive laser as the last resort, usually in painful blind eyes or eyes with very poor visual prognosis. Okay, always remember what I have mentioned before. In each pediatric patient, what do you need to remember? Correct refractive error and treat amblyopia. Yes, actually, the most common cause of defective vision in patient with congenital glaucoma is not glaucoma. It is amblyopia. So always remember, those children will not see not because of glaucoma, they will not see because of amblyopia, because usually, especially if it is unilateral, they will have high myopia, and if it is not treated properly, they will have anisometropic amblyopia with severe visual deprivation. So monitoring of IOP, corneal diameter, other parameters, amblyopia and refractive error should be managed aggressively. Okay, coming to this nice case, a case of vernal conjunctivitis with shield ulcer that came in 2022. And in 2017, they have that picture like this, and the examiner told the candidate to describe. Anyone can describe this for me?
This is the picture of anterior segment and a version of a lid. There is a giant papillae seen at the palpable conjunctiva.
Okay. Any specific name for this type of papillae? Yes, cobblestone papillae, exactly. Okay, this picture, anyone can spot what is this?
The shield ulcer.
Shield ulcer, exactly. And here we have this and this.
Pseudogerotoxon.
Yes, and here?
Limbal papillae.
Yes, severe limbitis or limbal papillae with that gelatinous appearance. So classification of vacancy, we have palpebral and limbal and mixed vacancy. Management of vacancy is very important. So we have general measures. What are the general measures that can be used?
We have avoid the cause allergens and we can go for the cold compressions.
Okay.
And the lid hygiene.
Exactly. Great. Allergen avoidance, cold compresses, and lid hygiene. And moisturizing cream for the skin around the lids. Actually, many of those children, because of the excessive rubbing, they have fissured and dry skin. And because of that dry fissured skin, they will have more itching. So moisturizing cream is part of the general measures that need to be used. Okay. Regarding the topical management,
We will start with the mast cell stabilizer like sodium chromoglycolate or
Okay.
antihistamines, amantadine, or we can start with the combination
yes, which
of
is
the
better, much better.
yes,
Yes.
ketotifen, or we can go for the mild steroid.
Okay.
And if this mild steroids and lubricants, if this steroid doesn't work or the patient is still have a complaint, then we can go for the topical cyclosporin 0.02%.
Yes, or 0.05.
5.
Yes, exactly. And one more immune modulator that actually it's now becoming trending. Yes, exactly. Tacrolimus 0.3% ointment. This is one of the game changers, and many new studies showing a great results in resistant cases and in chronic aggressive VKC. Actually, they have a very good results with tacrolimus. Okay, and antibiotics can be used sometimes, especially if the patient's having shield ulcer. Then you need to make sure to cover the patient with antibiotics. Then we have supratarsal steroid injections that can be used. What are the indications for supratarsal steroid injections?
If there's a severe palpable diseases, then we can use all other measures are fails and patients are non-compliant, then we can go for this injection.
And patients with severe keratopathy, non-healing shield ulcer, also those patients, you might need to give supratarsal steroid injection. We have many alternatives for that. One that is most commonly used, triamcinolone, 40 milligram per ml. That is used for supratarsal steroid injections. What are the complications that can happen?
Increased IOP.
Yes.
Pigmentary changes and
scarring can occur or this IOP can raise.
Yes.
Sometimes
cataract
CRO can also
CRO can happen.
Yes, if you give it wrongly, but usually supratarsal, it will be away from the ophthalmic artery and from the that part. But yeah, I think theoretically, at least, yeah, it can happen. Okay, systemic treatments.
Dr. Amar, what is the dose of triamcinolone which is given?
The
4
same one,
milligrams?
that vial that we used usually for that 40 milligram per ml. Usually you use 0.5 ml for each eye. That will be sufficient.
Right.
Okay. So then we have systemic treatment that can be used as well, like oral antihistamines. Yes. In some patients, you also, if the patient is having systemic allergy, then it's one of the approaches to refer the patient to immunologist, physician, and he will do for the patient all the investigation like IgE and all other inflammatory markers. And then also the systemic treatment will help a lot in controlling the disease in the eye. Okay. So we'll move to one of the questions that is repeated in almost every exam. Dr. Koshik, how much time we have?
Dr. Amar, I have a question. How will we treat the shield ulcer?
Okay, so shield ulcer, usually you need to treat the cause. So you will start by doing all the mast cell stabilizer, antihistamine, steroids, lubricant, and then you will see if the ulcer healed. That's it. If not, then you can go for supratarsal steroid injection. In addition to that, you can use contact lens. In some cases, you might need to do scraping, I think. If anyone also have any inputs in that regard.
If it's not healing, then we can go for even this amniotic membrane graft.
Okay.
over
Yes.
the ulcer, or we can do the tarsorrhaphy along with this. It can help.
Yes, in non-healing. Yes.
Yes,
I think,
and if
yeah.
the scar is mostly the scar will there, then for that we can go for this lamellar keratectomy.
Yes, or the phototherapeutic, yeah.
Phototherapeutic
BTK.
keratectomy.
Yes. Yes.
In steroid treatment,
We are not done for this. In case of VKC, you will just debride, and if you have a plug, you'll debride and put an empty. For stage 3 shield ulcers only, you'll put an empty. Stage 2, moving towards stage 3, you can do. And then if you're having any epithelial issues, if it's not healing, then you can do a PTK.
Yes.
Tarsorrhaphy is only done for neurotrophic.
Yes.
Yeah.
Can you repeat that, sir, please? Again, so everyone will hear it properly.
No,
For the treatment of shield ulcer,
Treating
please.
of shield ulcers only for when you have a plaque, then you will remove the plaque, and then if stage 2 moving towards stage 3, then you can put an AMT, or else you can conservatively manage. The reason for the shield ulcer forming and being superior is because the allergic reaction, the stasis, will be in close proximity with the epithelium, which is superior. So this inflammation will spill towards the cornea epithelia, and then that's how the breakdown and shield ulcer formation happens. So tarsorrhaphy is usually done for neurotrophic, and then in case of stage 3 ulcers, you'll debride it and then put an AMT to promote epithelialization. And this, if you are having a poor epithelialization because of any Bowman's membrane issues, because the desmosomal attachments are not forming properly, then you can do a PTK.
Thank you so much.
Contact lenses is an option. Contact lens.
Yeah, contact lens also is an option, sir. Yes.
Thank you so much. Dr. Kaushik, how much time we have?
sir, you can continue.
Okay, thank you. Okay, so regarding leukocoria, one of the most repeated questions in every exam, you will have it in many ways or in many pictures. So one of the most common, the congenital cataract. Then we have retinoblastoma, the life-threatening condition. Then we have others. So usually if you have any case with leukocoria, you must mention those two. Congenital cataract because it is one of the commonest causes of leukocoria, and retinoblastoma because it is life-threatening. So you should not forget about it. Other differential that is important as well, persistent fetal vasculature, whether it is anterior or posterior, ROP, especially the cicatricial and the total RD. Then we have toxocariasis, Coats disease, vitreoretinal dysplasia, retinochoroidal coloboma, large colobomas, and uveitis. Okay. So I will go through the congenital cataract, and I think retinoblastoma might be covered by the ocular tumors session. So I will cover the congenital cataract one. So for congenital cataract workup, usually you need to know firstly, does the patient have unilateral or bilateral congenital cataract? So if it is unilateral, usually it is only localized, it is only ocular cause. So you need to go for the history, past medical, prenatal, age of onset, history, family history, evaluation, and usually no need for lab investigations for unilateral cataracts, congenital cataracts. For bilateral, firstly, you will ask about family history, that's suggestive autosomal dominant inheritance, and you can always examine the parents, the father, mother, and examine the siblings. And if you find cataract, then mostly that is familial cataract, and then you will not need to do so much of lab investigation to diagnose the patient. If there is no family history, then you will go for clinical evaluation and then the laboratory workup. The lab workup usually will involve urinalysis, especially the reducing substances and amino acids, serum calcium, phosphorus, ferritin, glucose, torch titers, of course. And for the galactosemia, the galactokinase and galactose 1-phosphate uridyl transferase enzyme. So that is the general congenital cataract workup. So you need to know when to do the investigations, when you don't need to do the investigations, the laboratory workup, I mean. So in unilateral, usually it is ocular cause. In bilateral, if there is family history, again, then you don't need to do extensive laboratory workup. But if there is no family history in bilateral congenital cataract, then you will need to look for a cause if the patient is having any syndrome, or if there is any other systemic features that will help you to guide you to diagnose the patient. So history taking, here I will talk in the next few slides about congenital cataract specifically. So chief complaint, leukocoria, a child is having poor visual behavior, detailed history, age of onset, duration, similar history in sibling or parents, torch, drug and alcohol during pregnancy, trauma in unilateral cases. Even in very small children, you might have unilateral traumatic cases. I think those who are seeing a lot of children will have such cases, like 2 months, 3 months old infant with unilateral cataract. And then you will find small corneal opacity. You will find some signs in the anterior capsule that denotes that that patient had trauma with needle or something. So systemic examination for the dysmorphic features, subnormal mentation retardation in many syndromes, and auscultation for rubella because usually they have heart diseases, and for mitral valve prolapse. Ocular examination, visual acuity assessment, anterior segment abnormalities, especially in unilateral cases, corneal opacity, shallow AC, peripheral anterior synechiae in Peters anomaly, microcornea, posterior synechiae in uveitis cases, enlarged ciliary processes in persistent fetal vasculature cases, and intraocular pressure is extremely important to measure in every patient with congenital cataract, because the patient might have congenital cataract plus congenital glaucoma. Anyone can tell me 1 or 2 causes of congenital glaucoma and congenital cataract? Hello?
Sir,
Lower syndrome is one.
Rubella,
Yes, rubella can cause that. What else?
Peters anomaly. Yeah, Peters anomaly.
Okay, Peters usually will cause also corneal opacity. So, but for congenital glaucoma and cataract, one more important cause, anyone can remember?
Aniridia.
aniridia.
Aniridia definitely will cause both. And
Lowy syndrome.
what is it?
Lowy syndrome.
Exactly. Yes. And definitely fundus examination, or if there is no view, B scan for all those children. Okay, so regarding the prognosis and counseling for such patient with congenital cataract, what is the best age to do cataract surgery for infants? Anyone can help me?
If
So,
If it is unilateral, we have to do early, like 6 weeks.
How early?
less than
Okay.
4 weeks,
Okay, and if it is bilateral?
6 to 8 weeks.
Okay, so usually unilateral 4 to 6 weeks, bilateral 6 to 8 weeks. That is the best. And you have that window till the 16 weeks. 16 weeks old, that is the window. Usually the child will have good prognosis. If the child have the surgery beyond 16 weeks of age, usually the prognosis will be poor or, less favorable diagnosis. Why?
Amblyopia,
There is the
stimulus, stimulus
There is
deprivation
something,
amblyopia.
yes, there is something called critical period in the visual development of the infants. And that critical period usually, whenever you are doing the surgery late, you will have less favorable prognosis. But usually at the age of 16 weeks, after that, you will have a drop in the visual prognosis, because usually after 16 weeks, what will start to happen to that child if he didn't have the surgery?
Strabismus.
Nystagmus, exactly. So the patient will start having nystagmus, and usually nystagmus is one of the signs that the child is having a poor prognosis or less favorable prognosis. Definitely, we will do the surgery anyway, but we have to counsel the family that the patient will have less favorable prognosis. So usually for unilateral, 4 to 6 weeks, for bilateral, 6 to 8 weeks, and generally speaking, before 16 weeks, so you will have good prognosis. Usually, patient with developmental cataract will have better prognosis. Developmental cataract usually will be in the first 2 to 3 years, and usually it is progressive cataract. For example, patient with zonular cataract that start early zonular, then with time it progresses and it became more dense till it became dense cataract or total cataract. One important question: why we don't do the surgery before 4 weeks?
There is
Even
risk.
in unilateral.
Risk of general anesthesia.
Okay, that is one important thing, the risk of general anesthesia. Okay,
Chance
what
of
else? Yes, risk of glaucoma is very high before 4 weeks of age. Risk of post-operative that aphakic glaucoma is very high, because in those children the angle, as we know, is not fully mature, and usually they have a higher risk of glaucoma. Okay. So how to decide whether that child need surgery or not?
If the
Visually significant.
Okay,
Cataract.
exactly. But how to know it is visually significant?
It involves a visual axis 3 millimeters.
Okay, and
indirect
if it is posterior polar.
okay, if it is more posterior in location, and as you mentioned, doctor, yes, if you
indirect ophthalmoscopy, if you visualize the fundus, it is insignificant.
Yes, if you cannot visualize the fundus, then definitely that is a significant cataract. What else?
Close to the nodal point of the eye, that is significant.
Yes, whether it is more posterior, then it is more visually significant. Exactly. So the density of the cataract, the location of the cataract, the size of the cataract, whether it is 3 millimeter or less, and if you can see the fundus or not, and what we have mentioned earlier, if the child is having strabismus, if the child is having nystagmus, all those signs are definitive sign that that cataract is visually significant for sure. Okay. So in symmetric cataracts, if the patient is having bilateral, usually we do the 2 eyes within 1 week. Within 1 week, we don't do large interval between the 2 eyes. If the child is having non-significant opacity like blue dot cataract or small posterior polar or anterior polar cataract, those children need observation, because sometimes the cataract will progress. I have seen many children who start to have anterior polar cataract, but with time, they start developing cortical cataract or nuclear cataract around the anterior polar cataract. So never say to the parents of those children, you don't need any further follow-ups. You need to observe them at regular intervals to see if that cataract progresses and it became significant or not. Okay, so again, one debatable point in pediatric cataract cases, IOL implantation. So when usually we implant IOLs?
Usually we implant after 2 years, but nowadays even after 1 year, they say.
Okay, so there is one important factor.
7 months.
If it is unilateral, when you will implant?
Unilateral, actually we implant even in children. Means 1 year, 6 months to 1 year.
Yes, so if it is unilateral, you can implant as early as 7 months. If it is bilateral cataract and the child, for example, present at the age of 1 year, then you can also implant. So if it is unilateral, you implant as early as 7 months. If it is bilateral, you implant as early as 1 year. Okay? And always remember the ocular comorbidities. So sometimes you cannot implant, even the child is beyond that age. What are those ocular comorbidities?
Microphthalmos,
Microcornea, microphthalmia, exactly. So if the axial length is less than or equal 17 millimeters, you cannot implant. If the cornea is 8 millimeters or less, you cannot implant. In some references, if the cornea is 9 millimeter or less, you cannot implant. Okay. Also, if the patient is having anterior segment dysgenesis or pre-existing glaucoma, then you will be more skeptical to implant IOL. Okay, so regarding the IOL power, the target refraction, any one can help me in that?
That is postoperative, this one plus age is equal to 7. That is
Okay.
any formula.
Yes, so one formula is 7 minus the age of the patient. So for example, if the child is 1 year old, then you will aim for 7 minus 1 plus 6 hypermetropia. So you will do under correction 6 diopters.
Or you can use like 20% between.
Yes, yes. Between 1 and 2 years, you
2
will
years.
do 20% under correction.
And
2 to
10%.
2 to 4 years, you can do 15%, 10 to 15%. Then after 4 years, you can do 5 to 10% under correction. Actually, those numbers are a bit variable, that under correction also variable between one and other reference. But those are the two broad ways to choose IOL power for the children. Whether 7 minus age of the patient or percentage of under correction according to the age. Whenever the child is younger, you will do more under correction. Why you are doing under correction?
The growing eye is in the myopic, means it will become myopic.
Yes. So when you are doing under correction at the time of the surgery, then the child, when he will be 5 years or 7 years of age, he will be emmetropic. But if you put the same IOL power in the child without any under correction, when the child will be 7 or 8 years, he will be -5, -6, -7 diopters, myope. So to avoid the myopic shift or to compensate the myopic shift actually. Okay. Of course, we are not just using that methods that I mentioned. We also look for the other eye, especially in unilateral cataract.
But can you explain the first part?
Yes.
The 7 minus 2 is plus 5 diopter. Then the next sentence, IOL power is 30 diopter, which is plus 25.
Yes. For example, here, you mean here, am I right?
Yeah.
Yes. So if you do the biometry for the child and the child IOL power is 30 diopters.
Okay.
30 diopters, the child will be emmetropic, will be having zero refraction, zero diopter refraction. So you will do under correction. You will use plus 25. You will under correct by 5 diopters. That is in case the child is 2-year-old.
Okay.
In case the child is 2-year-old. For example, if the child is 3-year-old, then you will do 7 minus 3, that is plus 4. So you will put plus 26.
Okay.
Okay.
Okay. Okay.
Yes. So what I was saying, in unilateral cataract, you also check for the refractive status of the other eye. That is also very
One
important.
question.
Yes.
In case of unilateral cataract, where you have to do even in 7 months. So in 7 months, we will calculate it as 1 year. 7 minus 1.
7 months usually you will do, yes, you can aim for +7 or +6 hypermetropia.
Okay.
I mean for 1 year or less, you can aim for +6. You cannot aim actually for very high hypermetropia also, especially in unilateral cases, because the child will develop another type of amblyopia, which is anisometropic amblyopia, okay? So you cannot undercorrect so much. So +6, I think that is the
We have to reduce +6.
Yes. So the child after the surgery will wear glasses +6.
Okay.
You got it? The child will be hypermetropic post-operatively.
Okay, sir.
Okay. Okay, regarding the IOL types, if you are implanting rigid IOL, PMMA, we don't have other options. If we are implanting foldable, we should use acrylic hydrophobic. Hydrophobic, not hydrophilic. Hydrophobic is the most biocompatible for the children. Okay. Then we have single piece multi.
Sorry, Dr. Amar, could you please show the previous slide again?
Yes. So those are the causes why we are choosing acrylic hydrophobic IOLs. The excellent biocompatibility, it folds under controlled fashion inside the eye, because in such patients, usually you will have also posterior capsulorhexis. So you don't need the IOL to unfold very fast. So you can, like put the IOL safely, and the other advantages of hydrophobic. Then IOL types, we have 2 types, whether single or multi-piece. Usually, if you are implanting in the bag, we use single piece. If you are implanting in sulcus, you should use 3-piece IOL. Okay, regarding post-operative visual rehabilitation for children with congenital cataract. So usually we follow those patients post-operatively day 1, post-operatively 1 week, post-op 1 month, then every 2 to 3 months in the first year, then every 4 to 6 months for long-term follow-up. And in each visit, we should check for visual axis obscurations or opacities, check IOP, refraction, fundus, visual acuity or fixation in small children, and compliance of the amblyopia therapy. Post-operative rehabilitation. So one question about the aphakic glasses. For example, a child that you did for him lensectomy without IOL, for example, 6 months old child with bilateral cataract, and you did lensectomy without IOL, and the refraction came to be +15. So how much you will give the glasses? Anyone can answer?
+18 diopter.
Exactly. So you need to add the near +2 to +3 addition for the near. And in small children less than 2 years, usually we give only monofocal glasses, refraction +3 diopters for 1 to 2 years. 3 to 4 years, monofocal, refraction +2 diopters. Or you can start, if the child is starting the preschooling at 4 years, then you can start bifocal earlier. The full refraction for the distance, and +2 addition for the near segment. And always remember, those children have no accommodation. So you should give the full refraction. You should give the full refraction.
I have a question, Dr. If
Sir,
this is for a unilateral cataract, the patient having unilateral cataract, we will give this high number like +15, +18.
Okay, so in such cases, usually it is better to use contact lens, actually.
Okay.
Contact lens in unilateral cases is better, but in some countries and in some environments, it's not accessible. So if it is not accessible, you need to give the aphakic glasses and you need to do the patching. Okay, then you can aim for earlier IOL implantation, maybe at the age of 1 or 2 years, if everything is okay. The IOP is normal and everything is quiet, then you can aim for earlier secondary IOL.
sir,
Okay. Yes.
you told in case of unilateral cataract, we should implant like in 7 months of age.
Yes.
And bilateral cataract in 1 year.
If the patient came at that age, the age of presentation,
No,
with the cataract.
I'm asking about the IOL implantation. Like, cataract surgery has been done, patient has been affected. So when to implant?
Okay, so for bilateral cases, for example, patient who had done bilateral lensectomy at the age of 6 months,
Yes.
and now he is aphakic, then you can implant at the age of 2 years or 3 years. Why we wait for 2 or 3 years? Because you will have more better biometry, you will have more better IOL calculation, and you will have less myopic shift. Okay. So for bilateral cases, you can do secondary IOL implantation at the age of 2 or 3 years. Okay.
Unilateral?
For unilateral, you might need to do secondary IOL implantation a bit earlier, maybe at the age of 1.5 years or 2 years, because of the amblyopia. Especially if you do not have access for contact lens. But if you have access to contact lens, you can wait also for the age of 3 years or 4 years. So it depends on your, the accessibility of contact lens in unilateral cases. Okay. I think, yes, for congenital cataract, we covered many things. Lastly, the amblyopia therapy. It's very important for unilateral cataract cases. You need to start occlusion therapy as early as 1 week post-op. And you need to do aggressive patching regime, usually half waking hours for the infants. Okay. And you need to check the compliance each visit. For bilateral cataract cases, even if the patient had bilateral cataract and you did bilateral cataract surgery, even though that child might develop preference of fixation in one of the eyes. And in such cases, you will get to know that the patient is, for example, having right esotropia or left esotropia. So you need to start the patient on patching therapy. Okay. Or if the child is old and you can measure the visual acuity, if the child is having discrepancy more than or equal to Snellen lines, then you also start amblyopia therapy. Okay, complications of congenital cataract surgery. Anyone can say the complications? Hello?
In children, there is the scleral rigidity is a problem.
Okay, I mean post-operative complications. Dr.
Post-capsular means the visual axis opacification is.
Yes, very important.
Then glaucoma, increased IOP.
Yes.
More uveitis.
Yes, more reaction post-operatively, exactly. What else?
Amblyopia.
Amblyopia, definitely. What else?
Infection.
End of?
End of, yeah, it's very rare, but it can happen. One more important.
Retinal detachment.
Exactly, exactly. Especially in those children, usually you will do, anterior vitrectomy and there will be some vitreous traction, So risk of retinal detachment is there. And you need always to counsel the parents that those children will need follow-up for life because the risk of glaucoma, risk of retinal detachment can happen even after 10 years post-operatively, after 20 years post-operatively. So those children will need follow-up for life. So as you mentioned, glaucoma can happen, aphakic glaucoma, pseudophakic glaucoma can happen, visual axis obscurations or opacities, post-operative reaction, as you mentioned, and optic capture and retinal detachment. Okay, so finally we finished congenital cataract. We'll move to important topic, a case of 5-year-old patient with vision 6.6 and 6.18. That came in my exam in 2024. Another scenario, a 4-year-old child during school screening was found that right eye 6.36, left eye 6.6. How would you approach this patient?
First of all, I would like to do the cycloplegic refraction of this patient. If there are any refractive error, then I will prescribe and I will look the first patient on the slit lamp and do the examination of the fundus.
Okay, so you will do everything. You will do the anterior segment, posterior
And
segment,
posterior segment.
cycloplegic refraction, cover
And
test,
amblyopia, cover
test.
and extraocular muscles.
Exactly, exactly. So you need to do full workup, and if everything come to be normal,
then
or
it's
there is no organic cause, then
it's amblyopia. I would treat the amblyopia accordingly.
Yes, yes, exactly. So what are the types? What is amblyopia? Who can help us in that?
Amblyopia is defined as decreased in base corrected visual acuity due to stimulus deprivation or abnormal binocular interaction without any presence of any pathology in optic nerve, retina, or visual pathway.
Okay, great. What are the types of amblyopia?
It's strabismic, stimulus deprivation, anisometropic, ametropic, meridional.
Great, great. So in that question, the examiner asked, what is amblyopia? What are the types of amblyopia? And what are you going to do? So I said, give glasses if any significant refractive error or anisometropia, amblyopia therapy. Okay, then he asked, child 5-year-old, would you do amblyopia therapy immediately?
Sir, in PDIG study, one statement is been like that first give refraction, refractive correction, and wait for 3 months and then reassess, and if amblyopia persists, then start amblyopia therapy. I'm not sure of that, sir. Actually, I don't understand why
25 to 27% of the children will the amblyopia will improve only with refractive correction without any patching therapy. So usually you can start with giving the refractive correction and wait for 2 months, for example, 2 to 3 months. Then you will reevaluate the child. If still amblyopia persists, then you can start for patching therapy. Great. So what are other modalities than patching that can be used?
Sir,
penalization.
Atropine penalization. What is the percentage of atropine?
1%.
0.01%.
Yes.
No.
1%.
No, 1%. 0.01% is for the
myopia. Yes, for myopic. Yes, for
this is
patient
a 1%, I think.
Exactly. For progressive myopia, we can use even whether 0.01% or 0.05% atropine. But for penalization, you need to use 1% atropine. Okay. And when you will give the atropine regimen, I mean?
When that's an uncompliant patient.
Okay. But I mean, how you will give it? I mean, every day or
once weekly, once weekly.
Weekend.
Once or twice weekly, on weekends, maybe, you know, like, for example, Saturday and Sunday or so, 2 days a week or 1 day a week. Yes. Okay.
So, sir,
yes.
In amblyopia treatment, will you we say in that manner, first refractive correction, then recheck, and then amblyopia therapy. It has been accepted, no?
Yes, I think that will be acceptable also. Yes.
But in our PG life, we always read, if there is an amblyopia, just start the patching and something like that. But
Honestly speaking, it has many things to decide. For example, if the patient is living remotely, or if you feel that parents might not come back, or they might not be compliant on the visits or something, then you will give the correction and the amblyopia therapy on the same session. But if you feel that the parents are educated and they are aware and they will come for the follow-up visits on time, then you can start refractive correction, then you can do the amblyopia therapy on the subsequent visit. So honestly, it depends, there is no strict rules for
and
this.
subsequent visit will be after 2 to 3 months, or
Yes. 2 to 3 months will be enough to evaluate if still amblyopia persists or it is improving. If it is still persist, then you should start patching immediately.
So how long will you do the patching?
Patching, it depends on the degree of amblyopia, whether it is severe, moderate, mild. And also it depends on the age of the patient. Okay.
So is there any endpoint, sir? Up to this, we will try, then we will discontinue.
Okay, that we will come to this on the next slide, and I will also discuss this. Okay. So all this you already mentioned, types of amblyopia: strabismic, anisometropic, stimulus deprivation, bilateral ametropic, and meridional. Diagnosis in the absence of any organic lesion, and difference between, like the difference is more than two Snellen lines. And you have also that crowding phenomena that is very important because it is more marked in amblyopes. What is crowding phenomena? Anyone can answer?
Amblyopic patients, they are able to read single optotypes better than in a row.
Exactly. So because of that, the important lesson, you should always give the full line for the children when you are measuring the visual acuity. Okay. So you will not misdiagnose the amblyopes because they will have overestimated visual acuity if you use single optotype. So it's better always to use full line. Treatment, as we mentioned, you need first to diagnose any visible organic disease. Then occlusion and penalization. Okay, regarding the occlusion, for how long we will do the patching therapy?
Severe amblyopia, it might be 4 to 6 hours. In moderate, 2 hours. And in
okay,
mild,
usually mild 2 hours, moderate 2 to 4 hours, severe 6 to 8 hours. Okay.
Or mild, how much hours? 2 hours.
2 hours, yes.
For moderate, 4 to 6 hours.
4 to 6. Sorry, yes, 2 to 4. Sorry, and for severe 6 to 8. Okay. Severe amblyopia. How you will define severe amblyopia?
if the vision is less than 6/60.
Yes, less than 660. And moderate?
624.
Better than 660 and less than 618. And mild amblyopia better than or equal 618. Yes. So usually in amblyopia treatment, you need at least to do 6 months of occlusion, and you need to make sure that the family is compliant on the treatment. And if there is no improvement, then you can do another 6 months. So you can do full year. If there is no improvement in 1 year, even though the family is compliant, then you can say failure of treatment. Okay. Regarding the age, usually up to the age of 7 or 8 years, that is the age that usually the children will benefit more. But in children with anisometropic amblyopia or in children who have not done any patching before, even if the child is older than 8 years, even if the child is 10 years, 12 years, 14 years, you can always try patching therapy. Okay.
So penalization only in mild, penalization only in mild amblyopia, or it's
even moderate or
severe
severe,
amblyopia?
either moderate or severe. In my practice, at least, if the child never did any patching therapy, even if the child is in teens, if older children, you can always give a trial of patching and see. And usually the best prognosis is in anisometropic amblyopia, then strabismic, then the poorest prognosis in deprivational amblyopia usually.
So what I wanted to ask is whether we can do penalization in severe amblyopia or patching.
Sorry?
Whether we can do penalization in severe amblyopia or it is allowed only in mild amblyopia?
Penalization in moderate to mild amblyopia only.
Okay.
Because when you are doing penalization, you will use atropine to the normal eye. Okay.
Okay.
So with atropine, the vision, even in the good eye, it will not drop anything beyond 618. You know.
Okay.
So for the amblyopic eye to improve, you need to have better vision in the amblyopic eye.
Okay.
So for penalization, usually if the vision is 618 or better, it can work. 624 or better. Okay.
Sir, you told how long that 6 months or 1 year, sir, amblyopia therapy?
So in amblyopia therapy, you need to know if the family are really compliant or not. That is the most important part. So usually you need to ask them how many hours you are doing daily, how many days in a week you are doing. What about today? What about yesterday? What about the day before? You need to ask them specifically if they are compliant or not. If they are compliant and there is no improvement or no significant improvement in 6 months, for me, I will do it for another 6 months. If in 1 year there is no significant improvement and the parents are compliant, you can say it is failed treatment. There is no need to do any further patching. But if there is improvement, then you will continue on patching. And always remember that do not stop patching all of a sudden. You need to do weaning for the patching. For example, patient who had severe amblyopia and you start with 8 hours patching and the patient is improving, then you decrease the hours to 6 hours, then 4 hours. Then at 4 hours, the child became 6 in both eyes. Do not stop abruptly the patching. You need to do weaning. You should tell the family to do 3 hours, maybe for 2 months, then 2 hours for 2 months, then 1 hour for 2 months. Then re-evaluate the patient, because even sometimes even if the patient reach 6 vision in the amblyopic eye, relapse might happen.
Sir, weaning should be started from when the visual improvement is there.
When you reach whether 6 vision or the best vision that you reach the plateau. Whenever you reach the plateau, whether 612, for example, or something, the plateau vision, you need to do weaning. Okay, so do not stop patching suddenly, otherwise patient might have relapse. Or sometimes patient might have recurrence of amblyopia after 1 or 2 years, especially in small children. That can happen. Okay. So I finished the pediatric ophthalmology questions. Now we have few slides about strabismus. Do we have time?
Sir, yes, sir.
Okay.
Yes,
So I will go through it very fast. So first case, that is the most common question in strabismus in FRCS, esotropia. It is very common. Actually, for myself, I got 2 esotropia in the neurology station. Those are the two scenarios. One, 3-year-old child with acute onset of convergent strabismus for 1 month. And the second case scenario, elderly patient with lateral rectus paralysis. What will you do? So isodeviation is the most common strabismus that you will find in FRCS exam, whether you will have it in the Viva or you will have it in the clinical. So you need to know it by heart. So that is the classification that is mentioned in Kansky. We have accommodative and non-accommodative. The accommodative, we have refractive accommodative. It can be fully or partially. And we have non-refractive, which is the high AC by A ratio. And then we have the non-accommodative, the most important and the most common, the early onset or the congenital or infantile esotropia. Then we have other types like divergence insufficiency, divergence paralysis, sensory esotropia, consecutive esotropia, acute onset esotropia, and cyclic esotropia. Okay. Early onset esotropia, anyone can give me fast the features of infantile esotropia?
Yeah, there
Yeah.
It would occur after 4 months of age, and there would be large angle of deviation. There would be cross fixation, and it would mimic a bilateral 6-nerve palsy. It would also there would be no any refractive error, and patient will develop DVD in the late stages, and inferior oblique overreaction would also start developing late.
Okay.
Latent nystagmus.
Yes,
Manifest
exactly.
nystagmus, yes.
So we have, yes, we have 3 associations: latent nystagmus, DVD, inferior oblique overaction. All of them usually will start at the age of 2 years or beyond that. That is one thing. Second thing, the onset usually will be less than 6 months. Large angle of deviation, usually 30 prism diopter or more. A normal refractive error or for the age, or even less than, like 6 months old child usually will have +4 diopter, for example, hypermetropia. In those children, you even might have less hypermetropia, +1 or +2. Okay. And as you mentioned, cross fixation phenomena and asymmetrical optokinetic nystagmus, that is very important. What is the differential diagnosis of infantile esotropia?
this 6-nerve palsy.
6-nerve palsy, Duane.
Okay.
And
early
this
accommodative esotropia also.
Nystagmus, convergent nystagmus syndrome.
Yes.
Nystagmus blockage syndrome. Yes. Also, early accommodative esotropia can be one of the differential diagnoses. Some of the children will develop accommodative esotropia in earlier age. Okay, that also should be in our mind. So here we have the alternate fixation, which is usually present in many of the patients with infantile esotropia. Cross fixation, here the child is looking at the right side. He will use the left eye. And here he is looking at the left side using the right eye. So there will be pseudo limitation of abduction. How to know whether, how to test for abduction in such children? What to do?
Prolonged patching or doll
Yes.
side movement.
Exactly. Simply you patch that eye and do the doll's eye movement, and you will see the eye, the eye will abduct normally. Here the inferior oblique overaction in the right eye, inferior oblique overaction in the left eye. Okay. How to treat? Yes.
Sorry, this infantile esotropia, they can have alternating fixation also.
It's in primary gauge, no, sir?
What? Sorry?
Primary gauge, alternate fixation in primary gauge, cross fixation in side gauge.
Yes, definitely. Alternate fixation means when the child is looking at you, sometimes this one will be esotropic and he will fixate with the right eye. Sometimes he will fixate with the left eye and this one will be esotropic. So alternate fixation, alternate esotropia will happen. Okay, so he is not preferring fixation with one of the eyes. He is alternating the fixation. Okay, cross fixation, that is when you are checking the extraocular motility. You will see that this eye is not moving when the patient is looking at the left gaze, and this eye is not moving when the child is looking at the right gaze. Okay? Okay?
Yes, thank you.
Okay, so what is the treatment for infantile esotropia? always remember what I have mentioned, please.
Refraction and treatment of
Amblyopia.
myopia.
Refraction, amblyopia, refraction, amblyopia. So in some children, they might not have alternate fixation. They might have, for example, right constant esotropy or left constant esotropy. So before touching the child and do any surgery, you need to treat the amblyopia. And if the child is having any significant refractive error, like anything beyond plus 2.5, then you will give the full cycloplegic refraction and recheck the child to see if the esotropia improved or not. Okay, then you will proceed for the surgery. What is the surgery of choice?
Medial rectus recession.
Bilateral medial rectus.
Exactly. So why we are favoring bilateral medial rectus recession?
To this cross fixation.
Cross fixation.
Okay, yes.
To divide the resection. Okay,
all the answers are correct actually. So one thing is when the child is not having amblyopia, so it is better to do the surgery on two eyes. That is one reason. Secondly, recession is reversible, no, but resection is irreversible. That is one more reason. Thirdly, bilateral medial rectus recession is a symmetrical surgery. Symmetrical surgery. So the patient will not develop incompetence post-operatively. But if you did unilateral medial rectus recession plus lateral rectus resection, the child might have incompetence in the side gazes. Okay?
Can you repeat this, sir? Sir, what?
Okay. So we do bilateral medial rectus recession, firstly because usually those children will have no amblyopia. So it is better to divide the surgery on two eyes. Secondly, recession is reversible, but resection is irreversible. You cut the muscle, so it is irreversible. Thirdly, symmetrical surgery is usually better. Symmetrical surgery mean you do two muscles on two eyes, the same muscle, okay? Better than doing unilateral recess resect. When you are doing unilateral recess resect, for example, medial rectus recession and lateral rectus resection, you might have lateral incompetence post-operatively, okay?
Dr. Amar, this early onset esotropia, is it always bilateral or it can be unilateral also?
As we mentioned, if the child is having alternate fixation, so no amblyopia, you can proceed with the surgery. If the child is having constant esotropia in one eye, then you need to do amblyopia therapy. You patch the good eye, so the patient will start having alternate fixation, then you can do the surgery. Okay?
So he can, the child can present with unilateral infantile esotropia.
Yes. Sometimes the child will have, he will prefer fixation with one eye, and there will be one non-preferred eye. That can happen.
Okay.
In such cases, you should not do surgery until you have alternate fixation. So you need to do the patching therapy first. Okay?
Okay.
So in infantile esotropia, we have three approaches. The timing for the surgery, whether very early approach or early approach or late approach. Very early, usually between the 6 months and 1 year. Early, between 1 year and 2 years. Late, after 2 years. The most acceptable approach is the early approach. So you will do the surgery between 1 year and 2 years. Okay? But put in your mind always, you need to treat amblyopia and any significant refractive error before doing the surgery. If the child is having only horizontal deviation, so you will do only bilateral medial rectus recession. If the child is having inferior oblique overaction, then you will also do inferior oblique weakening procedure, whether myectomy or recession. Okay? Usually the acceptable goal is to leave the child with very small esotropia within 10 prism diopter. That is the ideal outcome. Okay.
Sir?
Yes.
As the time is very less, what do you say, surgery to be better done within 1 to 2 years. So if the child present to us like 3 to 4 months, So time is less for me. So whether in this case we will start patching therapy or whatever from the very beginning, or we should give refractive correction, though there is no refractive problem is there. So what we should do, sir? From very beginning we will start patching therapy.
For example, 4-month-old child with esotropia and he's having alternate fixation and cycloplegic refraction, for example, +2. So you will not give glasses and there is no amblyopia. You can start alternate patching 1 hour daily, okay, till you have stable angle, stable deviation, and you measure it at least twice. Then you can proceed for surgery. The timing of surgery is controversial. There are 3 schools. One of them very early, before 1 year. The second one, which is more acceptable even for the Kansky, they mentioned that one, that you will do the surgery by the age of 12 months, okay? At the age of 1 year and before the age of 2 years. So between 1 and 2 years, okay?
Okay.
The third school is the late school. That one now, you know, it's not very popular. That you should wait till the age of after 2 years, then you do the surgery. That is not acceptable much now. Okay.
So, what's the rationale for delaying surgery till 1 year?
Firstly, to treat the amblyopia. Secondly, to have stable deviation, you know. So whenever the child is very small, you will not be able to have proper measurement of the deviation.
Right.
But usually when the child is 1 year and 1 month, 2 months, you know, you can put the prism
Right.
and you can do the alternate prism cover test. So you will have more proper planning for the surgery.
Right.
Actually, one of the schools, as I mentioned, the very early approach, they said that we should do it before the age of 1 year, so the child will have more stereopsis. That is also acceptable approach.
Right.
Okay.
Thank you.
Okay. I will move to the accommodative esotropia. So we have refractive accommodative esotropia. Usually it happen at the age of 2 years, 3 years. Usually those patients will present and they have hypermetropia between +2 and +7. We have 2 subtypes, fully accommodative esotropia. Those children, when you give the full hyperopic correction, they will have 10 prism diopter of esotropia or less. Partially accommodative esotropia if they have more than 10 prism diopter esotropia. Okay. So for fully accommodative esotropia, you don't do anything. You just give the glasses and treat amblyopia if it present. For partially accommodative, you need at least to repeat the cycloplegic refraction twice. One of them you might repeat it using atropine to make sure that you are giving the full cycloplegic refraction and you treat the amblyopia. Then if there is still residual esotropia more than 10 prism diopter, usually anything more than 15 prism diopter, then you will do surgery for the residual angle. Okay. So here, child with partially accommodative esotropia is having large ESO without glasses. With glasses, still residual angle is large. Here, the child is having esotropia, but with glasses is almost ortho. Can you hear me?
Yes, sir.
Hello? Okay.
Yes, yes, we can hear you.
Non-refractive. Okay. Non-refractive accommodative esotropia, what we called usually high AC by A ratio. It has 2 types, convergence excess and hypoaccommodative convergence excess. So in those children, what is happening? When you are measuring the deviation for the distance, they are ortho. But when you are measuring the deviation for the near, they still have esotropia, or the discrepancy between the near deviation and distance deviation is more than 10 prism diopter. Okay. So for example, for distance deviation, they have 20 prism diopter ET. For near, they have 40 prism diopter ET. Okay. So the difference is anything beyond 10 prism diopter between distance and near. Okay. So we have 2 scenarios. if the child with the glasses is ortho at distance and still having deviation at near, so we will give the child bifocal glasses like this child. Here, this child, when he is using the distance segment, he is ortho at distance, okay? Here, he is looking at a near target using the distance segment of the glasses. He is having esotropia. But when he is looking through the near segment of the glasses, he is ortho at near, okay? So that is one scenario. The second scenario, the child is esotropic with glasses at near and at distance. So even with glasses, child still is having esotropia at near and at distance. What we will do in such cases? Any idea? Hello?
If with the glasses there, then we can go for the surgery.
Okay, what type of surgery?
Bilateral.
Yes.
Bilateral medial rectus recession. Recession for the distance angle. But the patient will still have esotropia at near. What can we do for this?
We can give the bifocal.
No, if you are already doing surgery, so you have another option.
Okay, this resection, the medial rectus.
No. See, you
We
will
will
do
give the
medial,
near it.
you will do medial rectus recession aiming for the distance deviation plus Faden procedure for the near deviation. Okay, so you can do something called Faden procedure. You will put posterior fixation sutures 12 to 14 millimeter from the medial rectus insertion. Okay, Faden procedure.
Sir, it is also the weakening procedure, no?
Can you,
Yes,
sir,
yes.
Dr. Amar, can
Yes.
you please say it again? If for the far
Okay.
distance, we did the
See,
session.
for example, you have a child with esotropia, 20 prism diopter at distance, and 40 prism diopter at near, okay? And that angle even after giving full cycloplegic refraction. So for the surgery, you will do bilateral medial rectus recession, aiming for the distance deviation for the 20 prism diopter, okay? So for example, you will do maybe 4 millimeter recession in both eyes, okay? And for the distance near difference, you will do Faden procedure. So you will do medial rectus recession plus Faden.
And of the medial rectus muscle.
Yes, Faden of the medial rectus muscle. You will put posterior fixation suture, non-absorbable suture, 12 to 14 millimeter from the medial rectus insertion. Okay. I will share with you a video for Faden and recession in the group after the lecture. Okay. Okay, I think.
So this is for a partial accommodative esotropia, right?
That is for high AC by A ratio. High AC by A ratio, when you have discrepancy between near and distance deviation. But for partially accommodative esotropia, you will usually the angle at near and distance, there is no much difference. There will be less than 10 prism diopter difference. So you will aim for the, you know, for example, 35 at near, 30 at distance. You will aim for 30 to 35, you know.
Okay, thank you.
You're welcome. We have also.
Are we supposed to know how to differentiate between the convergence excess esotropia and hypoaccommodative esotropia?
See, usually they do not go that much details, but we can go through it. So we have two types: convergence excess due to increased accommodative convergence, and hypoaccommodative due to decreased accommodation. So you have, you know, there is a ratio: accommodative convergence per accommodation. So in convergence excess, the problem in accommodative convergence, it is high. In hypoaccommodative, the problem is the accommodation is decreased. Because of that, the AC by A ratio is high. Okay?
And sorry for interrupting again and again. Can they ask us how do you measure the ACA ratio?
That can yes, I think I didn't have that question, but that can happen. You can have very easily go through the gradient method and heterophoria method. Very simple. Okay. Okay, so acute acquired comedant esotropia, which is called AACE. Okay, so that type of esotropia usually will happen after the age of 5 or 6 years. Okay, and child will have sudden onset of diplopia and esotropia with normal ocular motility. There is no limitation of abduction. Okay. So in such children, first of all, you need to rule out any neurological problems, any neurological causes. You might need to do neuroimaging, and after excluding all the neurological causes, you need to re-establish the binocular single vision, whether by giving prism glasses, botulinum toxin, or surgery. Okay, acute acquired comitant esotropia, AACE. It is rare entity, but now with the use of mobile devices and tablets, uh, it became more common than before. Coming
So
to
there
the
was a question, the previous you said the 4-year-old child suddenly developed the esotropia. That is this one, acute acquired accomitant esotropia.
See, for that 4-year-old, it might be accommodative, it might be acute acquired comitant esotropia. So you need to say that I need to do full
Check the
examination.
reflection.
I need to check the extraocular motility, rule out any neurological causes. If the child with full cycloplegic refraction is having high hypermetropia, so that is there is a reason for the esotropia. So mostly that is accommodative esotropia. But in such children with acute acquired comitant esotropia, usually they don't have high hypermetropia. So, there is no significant refractive error. But they differ from 6-nerve palsy because there is no limitation of abduction as well. Okay?
Thank you.
So, you need to rule out any neurological causes, and you need to treat the esotropia, whether with prism or Botox or surgery. Hello?
Sir.
Yes. Okay. Any questions? Okay.
No,
I
sir.
will go through. We have only, I think, 6 or 7 slides. I will go through them very fast. We have constant exotropia, early onset, infantile exotropia. That is just like infantile esotropia, usually will present before 6 months of age, but you need to be alarmed that congenital exotropia usually associated with neurological disorders. So such children, you need to refer them to pediatrician, okay, or neurologist. Okay, that is the most important point in such cases. Not like infantile esotropia, usually the children will be normal. Infantile exotropia, children, many of them will have neurological abnormalities, okay? Then you will proceed for the surgery. Intermittent exotropia, as we know, it usually present at the age of 2 years and usually start with good control, then fair control, then poor control. The children will start with exophoria that will appear when the child is fatigued or daydreaming, inattentive. Then the progression will increase with time. Okay. In intermittent exotropia, we have 3 classification. Anyone can tell them?
Sir, it is distance excess.
Yes, divergence excess.
Which might be pseudo or true.
Yes.
Then basic exotropia.
Yes.
Then convergence insufficiency exotropia.
Exactly.
Intermittent is true and simulated divergence. Simulated.
Yes. Yes. So we have divergence excess or pseudo divergence excess. How to differentiate between them?
By patching,
Yes, see,
patching or by
Giving
class 3
hyper.
class correction.
Yes. So if you have, for example, patient who is having exotropia at near 20 prism diopter, at distance 40 prism diopter, you will start by patching one of the eyes and wait for 30 to 45 minutes. Then repeat the alternate prism cover test at near. If it became 40 or 35, then that is tenacious proximal fusion. Okay, pseudo divergence excess. If it is still the difference between near and distance is high, then you can go for +3 diopter lens and you repeat the measurement. Okay. And if it became equal near and distance deviation, then this is high AC by A ratio. If the child still is having difference between near and distance deviation, even after the patching and after the +3 diopter lens, then this is true divergence excess, which is very rare. Okay.
So first step is by patching.
Yes. Firstly, you will do the patching and the check. If the angle, the difference between near and distance became less than 10 prism diopter, so that is due to tenacious proximal fusion. If still it is high, then you will use +3 diopter lens and see. If the angle became equal or less than 10 diopter, 10 prism diopter difference, then that is high AC by A ratio. If still after +3 and after patching still there is difference, then that is true divergence excess, which is very rare. Okay.
Okay, this +3 lenses in both eye or in a one eye?
In both eyes, definitely.
Okay. In both eye. The patching for the one eye and that is 3
Yes,
lenses.
patching for one eye. Patching for one eye is enough. Any eye. Okay. Okay. Treatment, spectacle correction, part-time occlusion. Sometimes it helps. Orthoptic exercises also, especially for convergence insufficiency type of exotropia. Orthoptic exercises will help a lot. Then we have surgery. For surgery, again, we have whether symmetrical surgery, bilateral lateral rectus recession, or we have unilateral recess resect. Okay. Long-term results of both surgeries are the same after 2 years, but before 2 years, unilateral recess resect usually give better results. Okay. How to decide if the patient is having unmaintained fixation in one eye, then you can do unilateral recess resect. If the child is having alternate fixation, then you can do whether unilateral recess resect or bilateral lateral rectus recession. Okay. Okay, I think I would stop here. Is there any questions?
Sir, in accommodative esotropia, I can ask the question here.
Yes. I'm done.
In fully accommodative refractive esotropia, the glass correction will may correct the condition. But in
yes, definitely.
partially accommodative esotropia, we are giving glass correction, we are repeating the cyclic diffraction. And so if it is not been corrected, we can go for surgery, sir?
Yes, so if the residual angle with glasses is more than 10 prism diopter, so that is partially accommodative, partially refractive accommodative esotropia, and you need to go for surgery for the residual angle. Residual angle. The angle with the glasses. That you will correct with the surgery.
And sir, how to you have to for the high AC by ratio for bifocals, we have to wean off by 6 to 7 years. We have to take off the
Yes,
bifocal.
yes, definitely. So if the child is having high AC by A ratio, esotropia, and he is ortho with the distance glasses for distance and ortho with the bifocal glasses for near, then at the age of 7 or 8 years, you can start weaning the bifocal segment. For example, if you start by +2.5, then you can give +2, +1.5, +1, till you remove the bifocal segment, maybe at the age of 10 years, 12 years, depending on the condition. Okay? Any other question?
So, sir, while doing weaning, so should we do the follow-up after like every 6 months?
Yes, definitely. You know, before doing the weaning, before decreasing the bifocal addition, you need to check it in the clinic. And you need to make sure that with the weaning, the esotropia is less than 10 prism diopter. Then only you will decrease the bifocal addition. And then after 6 months, you can decrease it further till you, stop the bifocal and leave the patient only on the distance glasses. Also
Sir,
for
sorry.
also for the fully refractive accommodative esotropia, usually after the age of 8 years, we also start to decrease the glasses in the same manner. For example, patient is wearing +6 diopter hyperopic correction, and he is now 9-year-old, for example. I will start give him +5.5 and check if the patient is still orthotropic or less than 10 prism diopter esotropia. I will give him +5.5. Next visit, I can decrease it again +0.5 diopter, and so on.
So weaning should be started from 8 years. 7 to 8 years.
Usually, yes. Weaning usually will start whenever you can do subjective refraction. Okay. Subjective refraction is one important prerequisite. The second prerequisite is that the child with the weaning still is orthotropic or within 10 prism diopter ESO. Those are the two, things that you need to have to do the weaning, whether for bifocal or for the full hyperopic correction. Any other questions? Hello?
Sir, such cases are given as a scenario, or we get patients also to examine squint patients?
Scenarios in the Viva usually, and you might have a patient in the clinic. In my exam, I got exotropia patient. My colleagues got Duane retraction syndrome patients. So also in other exam experiences, they got monocular elevation deficit. Yes, you might have it whether in clinical or in Viva. In Viva, usually it will be in a case scenario, or you might have a picture 9 years later.
Okay, sir, I need to know that in the clinical they give us the squint examination. We have to do this the prism test or only this cover and uncover and extraocular muscle?
See, in my exam, I started with Hirschberg, then cover test, uncover, alternate cover test. Then I told him I want to measure the deviation. Then he said, go, proceed. So he gave me prism, and I started doing alternate prism cover test at near and at distance with correction. So you need to be prepared.
Means they have prism to do us.
Yes, definitely. They have prism. And one of my colleagues, he just, hold the prism in ulta in the opposite side, and unfortunately he failed. So you really need to be familiar with prism. You really need to be familiar. You cannot use it for the first time, or, use it less frequently and come to the exam. You really need strabismus examination, visual field examination, ptosis, all those oculoplasty and strabismus. You need to do it many times before coming to the exam, please. Because they will figure out you from the first second that you are not familiar with this. You are not doing this so much. So usually strabismus station in clinical and oculoplastic station in clinic, those two stations usually, people will not pass because they didn't practice enough. For anterior segment, posterior segment, usually we do it, left and right many times in our clinics, but usually the defect will be in oculoplasty and strabismus. So please try to practice a lot before going to the exam, because they can figure out with their experience that you don't do it in your clinic.
Okay, thank you, sir.
You're welcome. Any other
Sir,
question?
one thing, Yes, sir.
Yes.
I have question. So I have always a confusion regarding stating the DDs when a patient given to me like with ASO and EXO both scenario, and the age variation is there. If the patient is in within the age of 10 years, and if the patient is given within the age of 10 to 30 years, and more than that. So can you simplify it? What we for SO and XO, what did we will tell? For young, already been told in Kansky, I got it. But if the child is of like 10 years, like patient is presenting SO, so what I
Okay.
will this is the age-wise scenario, sir. It just cross simplified as your experience.
See, for any case, you will start with the history, the age of onset of the esotropia. Then you will go with the anterior segment, posterior segment, cycloplegic refraction, motility examination. You will see.
Sir, in
Huh.
in Viva, will they allow me to ask history?
Yes, you can just say it very fast. You need to be systematic in your answer. So for me, whenever they ask me about that convergent strabismus case, I will tell them I would like to ask about the history without details, but you need to history of onset, any history of trauma, any history of febrile illness, neurological diseases. The relevant historical points, you can mention them very fast. Then you can proceed with the examination, and you will mention the important points in the examination, whether it is commitant strabismus, whether it is incomitant, whether there is limitation of extraocular motility, whether the patient is having any significant refractive error or not, and so on.
So, sir, in 10 years, like a child given to me like 15 years, presenting with esotropia. So,
Okay.
in that case, how I can proceed? What will be my DD? It might be scenario of EXO also. So tell me, sir,
Okay.
actually.
For esotropia, your DD, if that inward deviation start at birth, then infantile esotropia will be included. Then if that inward deviation started at the age of 3 years, then accommodative esotropia might be there. If there is limitation of abduction, then sixth nerve or Duane retraction syndrome will be included. Then if you have hypermetropic correction, like hyperopia, then accommodative will be included. So, it depends on the findings.
Okay. So in that age also we can include these uncorrected
Yes,
these.
yes. For example, patient who have never go to ophthalmologist, and he is now 15-year-old. And when I asked the father, he said he had that inward deviation since birth.
Yeah.
So infantile esotropy is there, even if he came at late presentation. Still, it is the cause.
And if the patient is like of 45 years age, how we can say the DD in adult? I'd say
Again, you have
the
to start
same.
with the history. History is very important. So history will guide you. If it is acute onset, if it is, chronic, if the patient is having diplopia, so that will be in the favor of acute onset. If there is a limitation, that is in the favor of, paralytic like sixth nerve. So history again is very important. Then your examination that will help you in, diagnosing the patient.
Okay, in such case, then I will start from history briefly.
Definitely. You need to be systematic. Otherwise, you will forget a lot of points. You need always to be systematic. The examiner will guide you. If you are, saying what he wants, he will say, okay, what else? What else? He will guide you. Don't worry.
Sir, one question, like an esotropia in a child.
Okay.
I think I am just giving a reference of a textbook OM. So, what is the causes of esotropia like that? So, author started like I will start it with life-threatening and the severe causes. So, in exam, practically, what we should do? We should do like this manner. Actually, the author wants to focus on the life threatening, the six arm palsy, retinoblastoma, and the ROP and the sight threatening is ROP, then I will say the infantile and something like that. So in exam, what should be the best approach? What would it be better to start with infantile or accommodative or like that, or we will say like that I will first exclude the life threatening and the sight threatening?
See, definitely you will exclude life-threatening by doing your full examination. So if you mentioned that you will examine fundus, and you will do the full examination, then you can exclude all the causes of sensory esotropia, like, cataract, congenital cataract, or optic disc hypoplasia, or retinoblastoma, So if you mentioned that you will take full history and you will do full examination, I think then you will rule out all the life-threatening and the vision-threatening conditions.
Okay.
Okay. Any other questions?
Thank you, sir, so much.
Okay. Thank you so much for your time, and I'm so sorry for very long class. I
Thank
hope
you
that
so much.
Thank you
it
very
Thank
much,
you,
sir.
Dr. Amar. Thank you.
Thank you very much.
You're welcome.
Okay,
Thank
good
you.
day.